Dacryocystitis is acute, subacute, or chronic inflammation of the lacrimal drainage system. It may be localized in the sac, extend to include a paracystitis, or progress to anterior orbital cellulitis. It very rarely causes posterior orbital cellulitis with proptosis and muscle limitation. Symptoms: pain at the side of the nose, redness, tearing, discharge, fever. Signs: erythematous, tender, tense swelling over the nasal aspect of the lower eyelid and extending around the periorbital area nasally. A mucoid or purulent discharge can be expressed from the punctum when pressure is applied over the lacrimal sac. Causes: almost always related to nasolacrimal duct obstruction. Uncommon causes include diverticula of the lacrimal sac, dacryocystitis, nasal or sinus surgery, trauma, and rarely a lacrimal sac tumor. Gram-positive bacteria are the most common pathogens. However, gram-negative and atypical organisms are seen more commonly in diabetics, immunocompromised, and nursing home patients. Differential diagnosis: facial cellulitis involving the medial canthus, dacryocystosis, acute ethmoid sinusitis, frontal sinus mucocele or mucopious L. Workup: transcutaneous aspiration of sac contents for culture and gram staining. CT scan of the orbits and paranasal sinuses. Treatment: congenital nasolacrimal obstruction. More than 90% of patients with congenital nasolacrimal obstruction undergo spontaneous resolution by age 1 year. Persistent swelling at the medial canthus may represent a widened nasolacrimal duct and dilated inferior meatus cyst that requires endoscopic marsupialization. Probing under general anesthesia. Fluorescein tinted irrigation saline is introduced to see whether it passes into the inferior meatus, or metal-to-metal contact may be obtained by inserting a probe in the nose. Endoscopic monitoring of syringe and probing is recommended for second procedures. Celastic tubes should be placed for at least 3 months, preferably 6 months. Dacryocystitis, DCR. Acquired nasolacrimal obstruction. After an attack of dacryocystitis, symptoms may resolve spontaneously. Medical, systemic antibiotics in the following regimen. Children older than 5 years and greater than 40 kilograms. Afebrile systemically well, mild case and reliable patient. Amoxicillin clavulanate 25 to 45 mg per kilogram per day per oral in 2 divided doses for children. Maximum daily dose 90 mg per kilogram per day. Alternative treatment: cefpodoxime, 10 mg/kg/day PO in 2 divided doses for children. Maximum daily dose of 400 mg. Febrile, acutely ill, moderate to severe case or unreliable parent, hospitalize and treat with cefuroxime, 50 to 100 mg/kg/day intravenously, IV, in 3 divided doses in consultation with infectious disease specialist. Adults. Afebrile, systemically well, mild case and reliable patient, cephalexin 500 mg PO 6 hourly. Alternative treatment: amoxicillin/clavulanate 500 1/125 of a milligram TID or 875 1/125 of a milligram TID. Treatment: febrile, acutely ill, or unreliable, hospitalize and treat with cefazolin 1 gram IV 8 hourly. The antibiotic regimen is adjusted according to the clinical response and the culture/sensitivity results. The IV antibiotics can be changed to comparable PO antibiotics depending on the rate of improvement, but systemic antibiotic therapy should be continued for at least a full 10 to 14-day course. Thank you.